Can you see the screen?
Yes.
Yeah, okay. Okay, so I won't go through this slide. This is, visually, you know what this is. Holistic care. Physical, social, psychological, spiritual domains, and care of the family and the patient. Holistic care. These ones I went through, the symptoms. So key points to consider. A person's symptoms don't always follow a predictable pattern, although some patterns can be seen and described. Symptoms are subjective, experienced differently by each person. So you have to understand that individualized treatment of symptoms is necessary. Symptoms are multidimensional, having multiple contributing factors and effects, not only physical. So, symptoms are a combination of mind, body, and spirit. So these are not very well. What is mind? People you might ask. Body, yes, we know. Mind, it's a psychological aspect mainly. But spirit, the spirituality, what we believe in life and what we expect after death or at death. So all these are a mixture of these symptoms. I went through this. So some of them are shared: physical, psychological symptoms, spiritual, and social. Okay, now we went through the disease trajectories. You will again and again go through these in your lectures. But I want to highlight the fact that even though physical well-being deteriorates at the last point in cancer, is the cancer trajectory, these psychological and spiritual fluctuations will go on occurring in these people. Thinking of cancer, what's going to happen, and all these fluctuations you need to address. This is in cancer, not non-cancer, but this is about symptoms. So we are not now confining ourselves to non-cancer. It's all about whole of palliative care. So even in cancer, this psychological and spiritual fluctuations can occur even when they are okay physically. And this is the other disease trajectory, mostly COPD and lung cancer. You can see the fluctuations, the physical with the physical fluctuations, you can see how the psychological fluctuations occur, as well as the social situation also. Dips are there and how it declines. At the point of death, the spiritual, now all the other components seem to be declining, but the spiritual, there's no decline, it remains the same. Sometimes it may even increase at the point of death. So these are diseases by the BMJ from Scott A. Murray is a reference. So well-being trajectories in patients with gradual decline. Now, this is mostly dementia and frailty with comorbidities. So we discussed this. So you can see in these people, if they are managed well, their social, psychological, and spiritual well-being can remain up to the final stage of deterioration. A frail person, frailty, I told you, they are vulnerable people. They have tendency to have adverse outcomes, including immobility, institutionalization, death. So they are elderly. They have physical and psychological and social deterioration can occur. So even though this shows a social static line, there are some people who have social decline as well with this is trajectory. Because, so for example, now if a person is frail and cannot move around, therefore cannot engage in family activities, the social function also comes to this line. Okay. Then the spiritual and psychological aspects also could deteriorate. But it need not be in frail people. In frail persons, if we manage them well, if we give them the proper supportive care and proper supportive network is established, even though their physical function is reduced, we can provide them the maximum um, well-being in social, psychological, and spiritual domains. Until such time when they really decline, uh, when they are nearing death, these domains will also go down. Okay. So this is a reference, but I don't know about the spiritual decline that is given here, which I think I will not agree, because spirituality may actually not decline in most people, even at the time of death. So this is a research published, but it may be otherwise in our population. It's not, this is not Sri Lankan population, or this is not Asian population. So the family carers, caregivers also undergo this process. This is in cancer. Okay, they are okay physically, but then similar to the patients who undergo these fluctuations in psychological and spiritual demands, the caregivers also can have them. So as I told you, symptoms are made up of mind, body, and spirit. Yes, this explains that. So what is good symptom control? Addressing these multiple symptoms and targeting symptoms to what matters most to the patient. That's the most important. What is the most distressing symptom to you? What is most concerning to you? What is the meaning of these symptoms to you? Is very important for us to find. So you need to address the multi-dimensional picture of these symptoms: physical, medical, nursing, emotional, spiritual, and social. So psychological assessment of a symptom: person's understanding of the situation, emotional well-being, anxiety, depression, person's expectation, fears, worries, psychological, emotional, all these are mixed. Prioritization of goals of life, awareness of prognosis, self-perception, physical and emotional, body. Now a person who is having a cancer of the lung, okay, our objective could be to, reduce the progression of the lung cancer. And the person who was a figure, maybe a prominent figure in the society among his peers, friends, may not even want to, go and meet the friends, go in front of other people to mix up with the community that he used to do, because of cachexia, because of the body image that the person is having. So that could further aggravate the loneliness and increase the anxiety, worries. So it's important to counsel them, talk to them, and then, make them realize and, value their the, the role in the society, accept the change in the role, change in the body image, and how to adjust to the current situation. And the grief and existential suffering. So existential suffering is the person's, ideas about the disease, the meaning of the disease, and what's going to happen, anticipation of the problems, and suffering because of that. So the grief due to what has happened. The question like, why me? What is happening to me? So all these are important. Nursing. Nursing it's mainly about the functional aspects: mobility, feeding, continence, wound care, skin integrity, mobility, falls risk, and all of that. Spiritual assessment. The meaning of life may be different to religion, as I told you, how spirituality impacts on their life. Coping mechanisms might be influenced by this. So examples of spiritual assessment are: one is a FICA, F for faith or beliefs, I for importance and influence, C for community, and A for address. So like, what is your faith or belief? And what things do you believe in that give meaning to your life? Is it important? Is it important in your life? What influences does it have? How you take care of yourself? Okay, so these questions. What role do your beliefs play in regaining your health? And the C, community. Are you part of a spiritual or religious community? Is this of support to you and follow? Is there a person or groups or people you really love or really are really important to you? A for address. how would you like me, your healthcare provider, to address these issues in your healthcare? So how would you want us to address these issues, spiritual issues? Okay. The hope questions. H, sources of hope, meaning, comfort, strength. O, for organized religion. P, personal spirituality. And E, for effects on medical and end of life issues. And social assessment, we've gone through on and on about this financial situation, patient, home, patient and the home, and interactions with the patients and the relations, about how the person is at home, is there good communication, loneliness, supportive network, community network, and the caregiver burden, and the interrelationship. So all of these count for social assessment of symptoms. So other aspects of assessment are about sexuality and body image, as we discussed. So palliative care assessment, these are important: medical, nursing, emotional, spiritual, and social. So comprehensive assessment is another way of looking at the symptoms. Looking at, now this is given in your guidebook as well, looking at the contributing factors to symptoms, the meaning of symptoms to the person, the behavioral response of the person to the symptoms, characteristics of symptoms. This is the comprehensive assessment. So if we go through that, contributing factors, different causal mechanisms, you should require different management responses. Characteristic of symptoms such as intensity, location, quality, temporal nature, frequency, associate pattern of disability. Meaning of symptoms to the person, beliefs about symptom and the effects on the person's physical, psychological, and social well-being. And then fourth is a behavioral response, such as actions that the person is taking to manage or cope with the symptoms. Okay, what is the action that the person is taking? So contributing factors, characteristics of symptoms, meaning of the symptoms, and behavioral response to symptoms. So characteristics of symptoms have to determine causal mechanisms as well. Assessment of the pain quality allows for a clinical diagnosis of the type of pain. Is it a neuropathic type of pain, or is it a dull ache? Okay. Assessment of the impact of pain helps you to determine an appropriate plan to minimize its effects. Assessment of how a person is managing their pain helps you determine treatment preferences. Okay. So this is an example how we assess the contributing factors, the characteristics of symptoms, and their coping mechanisms to manage pain. So comprehensive symptom management plan, assessment, identify, focus, implementation, intervention, and also you need to have an ongoing evaluation of outcomes of the intervention. So you do an intervention and you follow up. So approach effective management, it should be integrated. That means pharmacological and non-pharmacological management have to be integrated. It has to be targeted. So after assessment, you have to manage. It has to be targeted to the causes and the contributing factors, and it has to be tailored to the individual beliefs, preferences, circumstances. So this is the most important. So the two things that you have to remember. One thing is the comprehensive assessment, contributing factors, meaning of symptoms, behavior response, and characteristics. And the other one is approach effective management, integrated, targeted, and tailored. Okay, so these are some examples. Integrated approach that may include interventions aimed at one or more than one of the components of symptom. Example, to manage sensation of pain, opioid analgesics may be used, while at the same time you may teach the patient relaxation strategies. So pharmacological and non-pharmacological together. So pharmacological, the opioids, and non-pharmacological relaxation strategies. Okay. A targeted approach to ensure it's directed at specific causal mechanisms. So different pharmacologists might be needed to target different mechanisms or types of pain. So targeted to the causes. One pain may be coming due to the metastasis. So for that, you may need NSAIDs. Another pain could be due to compression of a nerve, the neuropathic. For that, you may need things like gabapentin. Okay. So effective management, a tailored approach. Number 3. So we went through the integrated management, targeted, and now effective manage, a tailored approach. to ensure it's suitable to the person's circumstance. So it's about pain we are talking. Okay. Patients who do not have caregivers, so adequate financial resources may require additional support to implement management strategies. So you have to understand the beliefs and the preferences of the person and then address that. So it just be a tailored, individualized approach. So this is actually talking about the same mechanisms. So key component of palliative symptom management, treating the underlying pathology, changing the sensation or perception of symptoms, diminishing emotional reactions, optimizing function. So this is an example I'm going to give you finally, because I think you have already had a lot of lectures. Now maybe time for lunch. So nausea, vomiting is an example that I'm going to give you. 70% of advanced cancer have vomiting. Unpleasant feeling of the need to vomit is nausea, and vomiting is forceful expulsion of the gastric contents through the mouth. Okay, so assess, review the history, investigation, review medications, examine looking for underlying causes, do the investigations. Okay, so understand the emetic process. Antiemetic drugs are mainly neurotransmitter blocking agents, so you have to understand which ones to use, and most times it's multifactorial. Okay, so there may be common causes like drugs, constipation, intestinal obstruction, renal failure, raised intracranial pressure, vestibular disturbance, cough, multifactorial. So management, you have to assess the symptoms, remove reversible causes, treat according to likely pathophysiological mechanism, choose an antiemetic for the specific transmitter. Okay, avoid triggers like foul smells and all that. Plan how to maintain control. So this is a diagram showing you that different areas in the brain could be contributing, like cerebral cortex, chemoreceptor trigger zone, vestibular system, pressure receptors. So different conditions. Anxiety can cause problems with cerebral cortex, drugs to the chemoreceptor trigger zone, motion sickness to the vestibular system, raised intracranial pressure to pressure receptors. And the gut also can give rise to the stimulants, radiotherapy, chemotherapy, affecting the vomiting center or intestinal obstruction. So the medicines could be serotonin receptor blockers like the 5-HT3 and 5-HT4, like the ondansetron, which are effective in chemotherapy-induced vomiting, or dopamine receptor antagonists, cholinergic muscarinic receptor antagonists. So these are medicines that you can the pathways for the medicines. Okay, this just to give you an idea. So the vomiting, treat according to the cause. Can be opioid-induced, cytotoxic chemotherapy, in such case, ondansetron, as I explained. Renal failure, maybe haloperidol. Functional gastric stasis, metoclopramide. Inoperable bowel obstruction, metoclopramide octreotide. So according to the cause, the medicine may change. And according to the cause, if it's hypercalcemia, rehydration, infection, antibiotics, raised intracranial pressure, dexamethasone, constipation, rectal measures and laxatives, anxiety, reassurance, and anti-anxiety. So, in summary, in management of symptoms, the principles: consider the whole patient, comprehensive assessment of symptoms, effective communication, the patient and the family, effective management, integrated, targeted, and tailored, correct the correctable, identify pathophysiology, optimize the function, and ongoing monitoring and assessment. So, thank you very much.